So do you have to taper off of ruxolitinib? I mean, if you're going to start fedratinib? We usually taper ruxolitinib.
Yeah, and that's a great question because I haven't seen any good studies saying that whether or not you do. I mean, I would just out of due diligence, but the reality is we just don't have data to really guide that.
I mean, it's not really my understanding is it's the symptoms that get worse, and maybe that's symptom control because of the JAK1, so it doesn't make sense that fedratinib would necessarily protect you from those symptoms. So it makes sense that you should, but
Harry, you're bringing up, regretfully, a very important point, and I'll say why regretfully. It pertains to clinical studies, which all require a washout period, and we ran into some disasters. And so even if we taper off gradually or not, the minute there is 2 weeks between studies, we ran into serious problems with a splenic rupture in a case because the spleen was growing in an uncontrolled fashion of drugs. So it's not so at this point, if I have to recommend, is not to have a period of no treatment, but to transit from one drug to the other without, you can lower the dose and move from one drug to the other and not interrupt for a long period. And I would also recommend that clinical studies have to modify their design and to say a few days off, but absolutely not 2 weeks or longer. It creates a problem.
Well, I think it's an important observation because it was true of the COMFORT-1 studies. They had to be off anything they were on. And if you look at the placebo or best available therapy arms, there was a lot of progression of symptoms in splenomegaly very early on.
Absolutely, and we have to be very aware of it, especially on patients that start with a highly proliferative disease. And we can identify them, the high white count, big spleens, and so forth. No, we shouldn't allow very long periods of treatment interruptions. Okay. Because even resistance to ruxolitinib does not mean total resistance. It means there is still some benefit, and you stop it and you will see it.
So let's talk about new things, but before we get to the new things, let me just bring up something that I think is incredibly cool in the pathogenesis of myelofibrosis, and that is in the patients with CALR deletion mutations, the frameshift mutations, and how that actually contributes to pathogenesis of the disease. So it's my understanding that CALR, which is a chaperones proteins through the endoplasmic reticulum to the Golgi to the cell surface, but it stays in the cell unless there's a mutation. And the mutation leads to a loss of that retention signal, and this truncated CALR is then excreted into the extracellular space and combined to MPL. And it actually is something then signals through MPL. And I got it right. I'm not a scientist anymore.
You got it right.
I got it right. So here's the question for my investigators here. Is anyone looking at small molecule inhibitors that block that interaction or monoclonal antibodies against CALR?
The answer is not only this, some people are even trying to develop immunotherapy, a vaccine based on that. Okay. Yeah, so that's going on. I hope I'm not going to see a CAR T based on that, but
yeah, I know Hans Hasselbach has actually already dosed a few patients with the CALR-related vaccine. I will see how effective that is. I think more than ever, if we do go with that approach, there might need to be approaches that actually augment the immune response, from what I've talked to him about.
And just to add to that, I mean, the fact that the mutant protein is expressed on the cell surface obviously provides for a novel neoantigen that can be picked up by the immune system. And we know there's a lot of immune dysregulation in patients with myelofibrosis. So the concept of checkpoint blockade in those patients in particular that CALR reticulum mutated may have rationale, because those patients, if you release that T cell repression, may actually be able to form an immune response against those cells.
Okay, before we get to some of the new drugs I want to discuss, I want to ask Robin about her experience in combining ruxolitinib, maybe fedratinib as well, but we'll say ruxolitinib with HMAs or other drugs to try to improve responses or gain responses.
Sure, yeah. So that's definitely something that I see a lot in terms of referrals, is patients that maybe are suboptimally dosed with ruxolitinib, or I haven't had the chance to see someone who is suboptimally dosed yet with fedratinib, but I'm sure that could happen. There's a few different approaches that have been looked at in phase 2 studies. Some of my go-to is that we know that it's safe and effective for patients with an erythropoietin level less than 500 to consider the addition of erythropoietin with ruxolitinib. And in some patients, you can actually get a pretty robust anemia response, and that allows you to potentially go up with ruxolitinib dosing. The other thing is danazol. Although less robust, we certainly can see a minority of patients respond to danazol in a safe and potentially effective combination. The other thing is that we have recent data on that look pretty promising. We have data this ASH on the addition of pomalidomide, a dose of anywhere between 0.5 up to 2 milligrams per day in combination with a stable dose of ruxolitinib, having some anemia response. We don't have many good options in terms of thrombocytopenia. Some people have combined ruxolitinib with hypomethylating agents. I haven't personally, although I've done that strategy. It seems most effective in patients that are having some sort of signs of disease transformation, maybe increasing blast count. But there have been some patients who've responded in terms of platelet counts. The addition of ruxolitinib plus thalidomide at just a stable dose of 50 milligrams a day after around 3 months of stable ruxolitinib therapy has been tried in a trial. And they saw a 75% improvement in platelet counts. So I think that more than ever, we have a couple of commercially available options that might actually help optimize our ruxolitinib dosing.